Today's class is on gastrointestinal emergencies and surgery, and it will be taken by Dr. Deepak Gupta. So, sir, I hand over the class to you.
So today's class, I'll be dealing with MCQs, mostly 25 to 30 MCQs on gastrointestinal emergencies and surgery. Hope you all must be appearing for the exam this in few days. The next week exam is there of EDIC 1, or some of them are for the next session. So those who are appearing for the exam just for the next week, I think they should be more focused on solving as many MCQs as possible. Don't go for much explanation. Just try to revise how many MCQs you can, so that many of the MCQs come as it is in the exam, you are able to solve them. Okay. So regarding today's class, as you know, previously also I have taken many classes. It will be an interactive type of class. I'll show you the question. Whatever you feel is the correct answer, you can just put in the chat box, and then we will see what the correct answer is and discuss why this answer is correct. Okay. So the two types of questions are there. So first I'll take the type A questions and the type K questions. The type A questions, as I previously also told, it's a bit easier than the type K ones. Type K ones are a bit difficult to solve. Okay. So the first question is, a 55-year-old man with a history of hepatitis C and alcoholic cirrhosis admitted to the ICU from ED with suspected upper GI bleed. History of esophageal varices requiring banding in the past year. Started on PPIs, octreotide in the ED, and gastroenterology was consulted. Soon after their arrival in the ICU, decompensated with cupus hematemesis and becomes hypotensive. Upper endoscopy for source control is not available for at least an hour, in addition to the continued resuscitation while awaiting gastroenterology. Which of the following is the most appropriate management for this patient? So you have to tell the most appropriate one. Out of the four, the first is place a nasogastric tube, start antibiotic for SBPs, prophylaxis, and start a low dose beta blocker to decrease portal venous pressure. B is intubate for airway protection and put a Blackmore tube for hemorrhage control. C is put a Blackmore tube for hemorrhage control, start antibiotics for SBP prophylaxis. And the last one is intubate for airway protection, place a Blackmore tube for hemorrhage control, and start antibiotics for prophylaxis. So you can put your answers in the chat box. D, someone has answered. Anyone else? D, most of you answered D. Let's see what the correct answer is. So the correct answer is D. All of you are correct. What was the D option? It was intubate for airway protection, put a Blackmore tube, and antibiotics for SBP prophylaxis. Now, cirrhotic patients with esophageal varices have decompensate very quickly and require skilled resuscitation to maximize their survival. The patient has a sentinel bleed before ICU arrival and started with appropriate therapy while in the emergency department. On arrival in the ICU, condition worsened, significant upper gastrointestinal bleeding. Airway management is critical. Intubation is necessary for gastrointestinal procedures such as Blackmore tube in the esophagus to avoid exsanguination while awaiting gastroenterology. So the most important catch here was you have to intubate the patient before putting a tube, because what that will cause, that will prevent aspiration. The airway should be protected before any endoscopy in a bleeding patient, or if you are putting this Blackmore tube or a Minnesota, any tube you are putting. often overlooked by the critical to improve outcomes in antibiotic prophylaxis to prevent SBP in cirrhotic patient with varicose hemorrhage. Starting a third generation IV cephalosporin has been shown to reduce all-cause mortality, infection-related mortality, rebleedings, and hospitalization length of stays. Okay. Inserting a nasogastric tube is not a correct option because it has never been shown to worsen varicose bleeding, but starting a beta blocker in the acute setting of hypotension is incorrect because it may worsen the hemodynamics. So beta blockers and nasogastric tube are not helpful. The correct option was D. Let's move on to the next question. You can read regarding the diagnosis and treatment of alcoholism associated liver disease. Very good article in hepatology in 2019. You'll get it on net. It's very nicely given. Second, this is a 38-year-old woman with 34 weeks gestation admitted to the ICU with altered mental status and jaundice. Right upper quadrant ultrasound reveals fatty liver. Which of the following is the most appropriate therapeutic intervention? Urodeoxycholic acid, cholecystramine, magnesium sulfate, or delivery of the fetus. You can put your answers in the chat box. D, someone has answered. I would request everybody, how many are there? Please try to attempt the questions. Even if it is wrong, this is not a final exam. You can correct yourself. Okay. D, someone has answered. Okay. Let's see what is the correct answer. The answer is D. The answer relies why this is happening. This is actually an acute fatty liver of pregnancy. Acute fatty liver of pregnancy is a life-threatening condition which occurs in the last trimester. Differentiation from the HELP syndrome and severe preeclampsia may require a liver biopsy. Acute fatty liver is associated with hepatic dysfunction, including synthetic functions. Ammonia and transaminases levels are higher, hypoglycemia is more frequent, and DIC is common. Treatment of choice, it is delivery of the fetus and supportive care. Okay. So it is acute fatty liver of pregnancy, and the best option is the delivery of the fetus because it is a life-threatening condition. Now, third, this is a 41-year-old female presenting with abdominal pain, nausea, vomiting, diarrhea. Examination shows her to be mildly jaundiced in AF and agitated with bibasal crackles on the chest auscultation and peripheral edema. Heart rate is 134, BP 76/45, respiratory rate 28, saturation 93 on room air, temperature is 39.6. She has mildly deranged liver function tests, a normal WBC and CRP. A beta SCG test suggests she is pregnant. What is the most likely diagnosis? Okay. You can answer in the chat box whether it is a thyroid storm, decompensated alcoholic liver disease, sepsis, malaria, or ectopic pregnancy. I think many of the clues are given in the question. You should get this one right. Okay. Yeah. Most of them have got it correct. It's a quite straightforward pregnancy patient with fever, tachycardia, hypotension, AF. So this is thyroid storm. What is that? The combination of symptoms is highly suggestive of thyroid storm. Pyrexia is not generally a feature of decompensated alcoholic liver disease, and sepsis is unlikely given the normal WBC and inflammatory markers. Now, the patient with malaria usually present with fever, headache, malaise, and gastrointestinal jaundice and respiratory symptoms can be seen. However, tachyarrhythmias and cardiac failures are not normally present. Now, let's see what exactly is the thyroid storm. Thyroid storm represents extreme of the spectrum of thyrotoxicosis, where decompensation of organ functions can occur. The transition into the state of thyroid storm usually requires a second superimposed insult, most commonly an infection, trauma, surgery, MI, decay, pregnancy, can precipitate this condition. Like in this question, what has happened is the patient was pregnant, they had given, and that has precipitated the thyroid storm in this patient. Any of the clinical signs and symptoms of thyrotoxic state may be seen. Pyrexia is almost universal. Okay. And when present in an unwell patient with known thyrotoxicosis, should prompt immediate consideration of thyroid storm. Cardiac decompensation, tachyarrhythmias, neurological dysfunctions, then liver dysfunction, nausea, vomiting, abdominal pain, jaundice are seen. Diagnosis of thyroid storm must be made on the suspicion but non-specific clinical findings. Treatment includes supportive thyroid-specific therapies to block the synthesis, block release, block T4 to T3 conversion, and block enterohepatic circulation. So this is all about the thyroid storm, which was precipitated by pregnancy. Let's move on. Next question. You are asked to admit a 48-year-old female patient with acute on chronic liver disease and grade 3 encephalopathy. She has been admitted under the medical team with acute kidney injury and deteriorating liver functions. There is no clear precipitant for decompensation on history from the family. They also state that she continues to drink heavily. On review, she has a normal saturation on 0.4, PO2 of 10. She is hypotensive, 76/40, tachycardic, catheter in situ, past 20 ml of urine over the last 8 hours. Bilirubin is 230, alkaline transaminase 56, creatinine is 478. Which of the following prognostic systems is likely to be the best predictor of outcome in this patient? Okay, you have to read the last line carefully. Best predictor of outcome you have to tell, whether it is a MELD score, Child-Pugh score, Apache 2 score, SOFA score, or Glasgow Coma score. You can answer in the chat box. Scoring systems is another very favorite topic of EDIC people. Few questions definitely you will get about the scoring system, whether it may be from the gastroenterology or the injury severity scores and other scores, or the score for pulmonary embolism, scoring for CAP. These are usually asked. You should be thorough with most of the scores. So far score someone has answered. Anyone more want to attempt this? Someone has said MELD score. Let's see what the correct answer is. The correct answer is D. What is D? D is the SOFA score. Correct. You have told correctly. See, this patient unfortunately appears to have multiple organ failure. That is the neurological, hepatological, cardiovascular, renal. Prognosis in this situation, especially in the absence of reversible precipitant, would be very bleak. Recent data suggests that the following 3 organ failure mortality approaches 90 to 100%. Interestingly enough, the generic organ failure scores appear to perform better at predicting outcome than specific liver disease scoring system. So this is not only a liver failure. It would have been only a liver failure. The MELD score would have been an answer. This is a multiple organ dysfunction. 4 of the organ failure is there. So at a recent systemic review, the SOFA score performed best with the area under curve and AUC of more than 0.9, reporting excellent discrimination. In contrast, Child-Pugh score and MELD score noted an AUC of 0.8. As such, if you were seeking to discriminate likely survival, the SOFA score would be the best choice to guide the clinical decision making in acute situation. So SOFA score was the best option out of the 4. Let's move forward. This is a 71-year-old woman admitted to the hospital with diarrhea, having been discharged from the hospital 15 days previously following treatment of metronidazole for Clostridium difficile infection. Past medical history includes hypertension, ischemic heart disease, diabetes mellitus. She also has CDI 3 months previously, which was also treated with metronidazole. She is having 5 to 7 stools per day, Bristol stool chart type 6 which is positive for C. difficile infection toxin. Examination and investigation shows a heart rate of 95, blood pressure 108/76, temperature 38, creatinine 94, and WBC of 12. The most appropriate therapy is oral metronidazole, oral vancomycin, fecal transplant, oral fidaxomicin, or oral rifampicin. Clostridium difficile, another very favorite topic of examiners. You will definitely get 1 or 2 questions on C. difficile. So you should be thorough with that. D, someone has answered fidaxomicin. Anyone more wants to answer? If you want to attempt, you have to consider three things in this patient. This is not the first one. The patient also had got a C. difficile infection 3 months previously. So the different treatment for first infection, for recurrent, for resistant, they are given different. So D, I think D is the most correct answer. The patient has got a recurrent CDI. Okay. Therefore, this current infection should be treated with fidaxomicin to decrease the risk of further recurrence. Severe cases of CDI not responding to oral vancomycin should be treated with high dose of vancomycin plus minus metronidazole or oral fidaxomicin. Now, oral rifampicin or intravenous immunoglobulins can be used, but there is no evidence to support the use. So fidaxomicin, what is fidaxomicin? It is, I think, not available in India at present, but here we have in the UK, we have been using it for many of the patients and it has got good results. Okay. So fidaxomicin is a macrocyclic antibiotic which is given orally, undergoes minimal systemic absorption. It has high fecal concentrations and limited activity against the normal gut flora. Side effect profile of fidaxomicin is similar to that of oral vancomycin, but it is considered more expensive. Studies have shown that fidaxomicin is non-inferior to vancomycin in the initial cure of CDI and superior in reducing recurrence. So this is the point. Fidaxomicin prevents recurrence. Vancomycin could also have been used, but because this is a recurrent infection, you have to use fidaxomicin. Recurrence occurs in approximately 20% of the patient treated with metronidazole and vancomycin and can be treated with the same initial agent. Subsequent recurrence should be treated with fidaxomicin because of the increased risk of further recurrence. Fecal transplant rarely has adverse effects and causes resolution of CDI in 81% of the patient. It is used as a last resort option, mainly due to practical and aesthetic concerns. Okay, so fidaxomicin was the correct answer. So regarding C. difficile infection, recently many changes have been made in its treatment recently. So you go through the latest IDSA guidelines for treatment of C. difficile infection, because C. difficile is a very favorite topic. I've just put a screenshot of this for recurrent episode, for first recurrence, for subsequent recurrence. What are the antibiotic regimes, because some changes have been made in the treatment. You should be thorough with this. Okay. So to read it completely, this IDSA guidelines of 2021 focused update of Clostridium difficile, very nice guidelines about C. difficile infection they have given. You can read this on net. Now regarding penetrating abdominal injury, the following are true except. Okay, this is surgical type of question. Most common cause of death in the first 24 hours is hemorrhage. Peritonitis is a hemodynamically stable patient is an indication for laparotomy. Most common injured organ in penetrating stab wounds is the liver. Chest X-ray is an insensitive test for diaphragmatic injury. Negative fast scan is a high negative predictive value for injury requiring laparotomy. Yeah, you can answer in the chat box. All are true except. So you have to find which is the false statement out of the following. Can answer anyone more? E, someone has answered. E. Anything more you think of, you can answer in the chat box. Let's see what the correct answer is. So answer E is correct. What was E? E is a false statement. Why false? A negative fast scan has a high negative predictive value for injury requiring laparotomy. This is a false statement. Rest all the four options are correct. See, now the penetrating abdominal injury may cause injury to the vascular structures and hollow viscus. Peritonitis may reflect the leakage of digestive tract contents from hollow viscus and is an indication for laparotomy. Most commonly injured organs are liver 40%, small bowel 30%, diaphragm 20%, and colon 50%. Chest X-ray is a relatively specific for diaphragmatic injury with abdominal stab wound, although low in sensitivity. Abdominal CT is the investigation of choice for assessment of injury to the liver and spleen, but lacks sensitivity for detection of the mesenteric, hollow, visceral, and diaphragmatic injuries. A negative fast scan has a negative predictive value for laparotomy of only 60%. Okay, so that was the false statement. It may miss free intraperitoneal blood and will not reliably identify injuries for structures such as the diaphragm and bowel, which requires operative repair. So E was the correct answer in this. The following are common laboratory features of toxic megacolon except metabolic alkalosis, hypokalemia, raised hematocrit, anemia, or leukocytosis with left shift. Yeah, you can answer. Toxic megacolon, a complication after C. difficile or necrotizing enterocolitis. What are the features? Okay, someone has answered C, again C. Let's see what the correct answer is. C is the correct answer. Why? Raised hematocrit not occurs, rest all things are there. Okay. The enteral loss of potassium and fluid may cause volume depletion, hypokalemia, metabolic alkalosis. Although these patients are often volume depleted, anemia is usually due to the blood loss per rectum with a lowered hematocrit. Okay. Leukocytosis is seen as a component of inflammatory response. Left shift refers to the fact that the severe inflammation or infection, a greater proportion of immature neutrophils are present in the circulation due to excessive cytokine release. So, hematocrit was the correct answer. It is not there. Raised hematocrit. Now, this is a 33-year-old woman presenting with the right upper quadrant pain, generalized abdominal swelling. She is previously well and takes no medication other than oral contraceptives. Past medical history is unremarkable apart from deep vein thrombosis in pregnancy. Hepatomegaly, ascites, and peripheral edema are present on clinical examination. Ascitic fluid analysis reveals a neutrophilic count of 10 to the power 3 and serum to ascites albumin gradient ratio of 1.3. SAG is 3. 24-hour urine protein concentration is 90. She denies alcohol excess. What is the most likely diagnosis from the below? Whether it is acute alcoholic hepatitis, Budd-Chiari syndrome, SBP, metastatic disease, or nephrotic syndrome. So what do you think it is? Right upper quadrant pain with hepatomegaly, ascites, peripheral edema, and the ascitic fluid picture given here.
Disney Hotstar இருக்குல்ல உன்கிட்ட அதுல சித்தா CHITHA சித்தான்னு ஒரு தமிழ் படம் இருக்கு.
I think if you want to answer a question, you unmute or you can mute. Yeah. D, someone has answered metastatic disease for this. Anyone more wants to attempt this? Okay, let's see what the correct answer is. It's B. What is B? It is a Budd-Chiari syndrome. Why? See, Budd-Chiari syndrome is caused by the occlusion of hepatic venous outflow by a variety of conditions, including inherited thrombophilia, use of oral contraceptives, pregnancy, chronic inflammatory conditions, or tumors. It presents with classic triad of ascites, hepatomegaly, and abdominal pain, or may present insidiously. So, the classical triad is definitely present in this patient. This patient has got ascites, hepatomegaly, and abdomen. She presented with abdominal pain. So, Budd-Chiari syndrome was the correct answer in this. In the latter case, a collateral circulation has time to develop ascites, and ascites may be minimal. Doppler ultrasonography is a reasonable, sensitive, and specific investigation, but the gold standard is the hepatic venography. Management of Budd-Chiari includes medical treatment of ascites, diuretics, and sodium restrictions, anticoagulation, reduction of venous pressure, which may require a portosystemic shunt. The serum ascites gradient differentiates between portal hypertensive ascites and other causes and is considered more accurate than the older classification of exudate and transudate. Now, other options we are ruling out. Nephrotic syndrome can also cause ascites and peripheral edema, but defined as a urine protein excretion more than 3 gram. Okay, this was not there in this. And SBP is unlikely if a neutrophilic count of more than 250 is found in the ascitic fluid sample. So, Bhattacharya was the correct answer in this. Next, this is a 60-year-old man with a history of heart failure with reduced ejection fraction, COPD, requiring home oxygen, GERD, presents with dysphagia of solid and liquid foods, which has worsened over the last year. The esophagoduodenoscopy is performed, which reveals normal esophageal mucosa with negative biopsy results. High-resolution manometry reveals an integrated relaxation pressure of 20 DCI less than 100 of 100%. Esophagogram demonstrate a dilated esophagus with poor emptying of barium. Which of the following therapies would be the most appropriate? Whether it is Nisan fundoplication, botulinum toxin injections, esophageal pneumatic dilatation, or peroral endoscopic myotomy. Kind of difficult type of question. We usually don't encounter such questions in critical care, but such questions can come in your EDIC exams. So you should know this. A, someone has answered. Anyone more wants to attempt this? If you know the diagnosis, what is the diagnosis with the signs and symptoms given in this patient, then only you will be able to get the correct answer. Someone has answered D. Let's see what the correct answer is. The correct answer is C. Why? The correct answer is esophageal pneumatic dilatation, because what is the diagnosis? Diagnosis in this patient is achalasia. What is achalasia? It is a primary esophageal disorder with a pathologic consequences of degeneration of ganglionic cells in the meandric plexus of esophageal body and lower esophageal sphincter of unknown etiology. The degeneration leads to insufficient relaxation of the lower esophageal sphincter. Esophagography typically reveals esophageal aperistalsis with proximal dilatation and minimal lower esophageal sphincter opening, resulting in a bird's beak appearance. Okay. At present, achalasia is incurable and management consists of palliation of symptoms. Patient who felt to be good surgical candidates, laparoscopic myotomy with partial fundoplication is an effective strategy for long-term resolution of symptoms. However, the patients who are risk of surgical candidates, initial treatment is graded pneumatic dilatation is recommended. So in this patient, the final treatment would have been myotomy and partial fundoplication, but the initial treatment is graded pneumatic dilatation and palliative symptoms. Okay. Now, ruling out other options, complete 360-degree fundoplication would exacerbate the symptoms of dysphagia and is not appropriate. Botulinum toxin is an attractive and user-friendly approach which interrupts the release of acetylcholine from presynaptic vesicles, causing interruption of neurological components, but has no effect on myogenic components of LES. Although the initial 1 month response rate is close to 75%, the therapeutic effect wear offs and approximately 50% of patients relapse and require repeat treatment or at 6 to 24 months interval. POEM, it is a novel method of endoluminal myotomy performed by traversing the esophageal mucosa. Although the technique is promising, it requires advanced endoscopic skills. In addition, POAM has been shown 50% of patients to promote further acid reflux. Although such a question is a difficult question, not much related what we can see with the critical care, but I have specifically put this question because such questions can come in the EDIC exams. You can only do is guesswork if you don't know anything about it, or just if you have read somewhere and you get it correctly, then only you will get it correct. I think the time is less, or else we'll not be able to complete some K-type questions. I'll go directly now to the K-type questions. Few we will do. If time is left, then again I can come to the type A questions. Okay. I'll skip some questions of type A, we'll go to the K type ones. And then if time is left, we can again do some questions of type A. So type K, these are considered the difficult questions because in this question, every option you have to consider it as a single MCQ. Okay. So first, regarding Clostridium difficile associated diarrhea, you have to answer in the chat box as TF, true or false. Okay. So prior use of penicillins or macrolides is not a risk factor. Probiotic have been shown to reduce mortality from C. difficile and critical care. Meticulous use of alcohol-based hand gels reduces the C. difficile transmission. Surgical resection of the infected colon may be required, or a toxin produced by the bacillus is responsible for the disease. So about C. difficile, you can answer in the chat box which of the following statements are true and which of the following statements you feel are wrong. Just think about it and put it in the chat box as TFFTT, whatever you feel. Okay, I've got an answer. TFFT. C and E are true. Okay, okay. Let's see what the correct answer is. So correct answer is the last two are only the correct statement. That is, a surgical resection of infected colon may be required and a toxin produced by bacillus is responsible for disease, while the first three statements are wrong. Why? Let's see. See, C. difficile is an anaerobic gram-positive bacillus, which is the commonest cause of infective diarrhea in critical care. It produces a toxin which leads to bowel mucosal inflammation, dilatation, and necrosis. Disease ranges from mild, which may require no treatment, to severe colitis and toxic megacolon, which often require surgical resections. Mortality with C. difficile in critical care is approximately 20%, and the risk factors include prolonged ICU stays, use of PPI, enteral feeding, and current and recent use of bacterial agents. Now, regarding the other options, all broad-spectrum antibacterial agents may increase the risk of C. difficile, overgrowth, and diarrhea, but the quinolones and cephalosporins are particularly strongly associated. Treatment with antibacterial agents such as metronidazole is the first-line therapy, with resistant cases treated with vancomycin. Other effective agents are ticoplanin or fidaxomicin. We have seen one question of fidaxomicin previously. Okay. As many as 20% of the cases may require multiple courses of antibacterials. Prevention of disease is important. Limitation of the use of PPI, carefully stewardship of antibacterial, and rigorous infection control procedures are key to disease control. Alcohol-based hand gels are ineffective agents in C. difficile, so soap and water should be used. Probiotics such as lactobacilli have been found to reduce the rates of C. difficile positive fecal samples, but no mortality or length of stay benefits have yet been shown. Okay. So this was the second question on C. difficile. Previously also we have seen very common and favorite topic of EDIC. That is why I put these two questions. What happens in India, what we have is we don't do much and we don't get positive results for C. difficile. But here it is quite common and very important infection. So while reading the questions and preparing for an international exam like European exam, you have to think what diseases and what things are more common over here. And then you have to read and learn those topics accordingly. Infective topics, tuberculosis topics, this doesn't exist here. So that questions are rarely come. The diseases which are over here, these questions will be asked. Okay. Next, with regards to acute colonosudal obstruction, which of the following are correct? Okay. There must be clinical and radiological evidence of large bowel obstruction for diagnosis. It is also known as Ogilvie syndrome. Ischemia and perforation rarely occurs. Oral neostigmine has been shown to be effective in 80% of the patients. Endoscopic decompression can be performed as an alternate to surgery. I think it's a direct question. Such questions are given in many MCQ books. Most of you must have read this question also. I think it is a general type of question, that is why I put here. It's quite simple. I think most of you should get this correct. B and E are true. Anyone more wants to attempt? You can put your answers in the chat box. Okay, let's see what the correct answer is. So the first, second, and the last are correct. The C and D are the wrong answers. Why? We'll see why it is. In acute colonic pseudo-obstruction, there is a clinical and a radiological evidence of a large bowel obstruction in the absence of mechanical obstruction. Okay. Patient will probably fail to pass stool or flatus. They are likely to have abdominal pain and distension, and they may vomit. Clinical features are similar to that of a mechanical bowel obstruction, which should be excluded. Plain X-ray will show dilated colon, usually the cecum and colon, proximal colon. The diameter of the dilated bowel is important as the risk of perforation increases with increased dilatation. Free air suggests perforation. Water-soluble contrast-enhanced CT or radiograph demonstrates dilated large bowel in the absence of mechanical obstruction and should be performed in all the patients. The underlying pathophysiology of pseudo-obstruction is unknown, but may involve dysfunction of autonomic plexus in the gut wall. The treatment includes supportive care and meticulous attention to fluid balance, electrolytes levels, and hemodynamics. One of the option was neostigmine. So neostigmine is the most widely used pharmacological agent. It should be administered intravenously with close cardiac monitoring. Invasive treatments include endoscopic decompression, radiologically guided percutaneous cecostomy, and surgery. Surgery should only be attempted in patients with imminent or confirmed perforation, as the mortality is high. So this was a question on acute colonic pseudo-obstruction. We'll move forward. Regarding intra-abdominal pressure monitoring, which of the following are correct? The standard way of monitoring intra-abdominal pressure is via an intravesical catheter. An intra-abdominal pressure of less than 20 is normal. Intra-abdominal compartment syndrome rarely requires surgical intervention. Following laparotomy, primary closure of the wound should always be attempted. And increased FRC leads to gas trapping in abdominal compartment syndrome. Again, one of the favorite topics in EDIC, abdominal compartment syndrome. You will get some questions on this. These questions are very commonly given in many of the MCQ books. A and C are true, yes. Anyone more wants to attempt this can put their answers in the chat box. Okay. Let's see what the correct answer is. So only A is correct. That is, the standard way of monitoring is via intravesical catheter. Rest all are false. Why? Let's see. See, abdominal compartment syndrome is most commonly occurs in patients with primary abdominal pathology, such as hemorrhage, abdominal surgery, peritonitis, large hernia repairs. It can also occur in patients who have pathology elsewhere, such as burns, sepsis, massive fluid resuscitations. Normal intra-abdominal pressure is 6 mm of Hg. Pressure of more than 12 is classed as intra-abdominal hypertension. ACS is defined as a pressure more than 20 with organ dysfunction. I think I will not go in more in explanation, will not be able to complete more MCQs. You can read this abdominal compartment syndrome. It is given nicely in many of the books. You should be thorough with the management and abdominal compartment syndrome. It can come in EDIC 1 exam, also in EDIC 2 with cases of any abdominal cases there. They can take you to abdominal compartment syndrome questions. Okay. Next, this I just given a screenshot of this. It is a clinical guide to management of intra-abdominal hypertension and abdominal compartment syndrome in critically ill patient. You can go through this it was published in the Critical Care 2020. It's a very nicely written article. It covers most of the things of abdominal compartment syndrome, okay, and intra-abdominal hypertension. Now, next, regarding the management of severe acute pancreatitis, okay. Patients with Glasgow score of 3 or more should be managed in critical care unit. Enteral feeding should be avoided for the first 7 days. Empirical antibiotics should be prescribed. ERCP should be considered in patient with SAP and jaundice. And necrotic pancreatic tissue should be surgically debrided as soon as possible. One more important topic in abdomen is pancreatitis. You will get some questions on this. If you want, you can answer in the chat box. Very direct question on pancreatitis. I think most of you should get this correct. So TFFT, any more wants to answer? They can put their answers in the chat box. No? Yeah, someone again wants A, D, and E is correct. Okay, okay. Let's see what is the correct answers. So only D is correct. Rest all are false statement. What is D? Endoscopic ERCP should be considered in patient with severe acute pancreatitis and jaundice. Rest all of them are false. Why? Let's see. See, acute pancreatitis, up to 20% episodes of acute pancreatitis are severe. Commonest causes are alcohol, gallstones, but may be due to trauma, drug, malignancy, and viral infections. Features are this is complete explanation regarding the acute pancreatitis. I think you can get lots of material about acute pancreatitis in your books. Go and read this topic thoroughly. Important questions usually on acute pancreatitis comes on whether antibiotic is to be given or not, when the feeding should be started or not. And scoring systems are also very important in acute pancreatitis. The Glasgow coma score, the bicep score, the previously, what was that, Ranson scores and this kind of things. So I think it would be difficult to complete more MCQs if I go on teaching complete acute pancreatitis. You can go and read in any of the books. We'll move forward to cover few more MCQs, okay? Regarding hepatorenal syndrome, HRS, one more favorite topic. It is commonly overdiagnosed in patients with cirrhotic liver disease. HRS type 1 has the poorest outcome. Kidneys from patient with HRS are suitable for transplantation. The condition is associated with splanchnic vasodilatation. Terlipressin must be given by infusion. So you can put in your answers in the chat box. Very common type of MCQ on HRS. Yeah, someone has answered. All are true. Any more answers? If anyone wants to, you can attempt that. Even if it is wrong, it's not an issue. Even B, C, D, E are true. B, C, D, E are true. Yeah. Anyone else wants to attempt? You will get such MCQs in the many of the MCQ books. Very, very common MCQ. You should know this. Okay, let's see what the correct answer is. So all are true except the last one. What was the last? Terlipressin must be given in infusion. Terlipressin is never given in infusion. It is given as boluses. So HRS, it is frequently misdiagnosed. The diagnostic criteria is cirrhosis, creatinine more than 133, absence of shock, hypovolemia, no nephrotoxic drugs, no parenchymal renal diseases, less than 50 red blood cells per high power field on microscopy. Two types are there, type 1, type 2. So type 1 and type 2 are traditionally recognized, but more recently type 3 and 4 have also been identified. Prognosis in type 1 is poor with a median untreated survival of 2 weeks. Type 2 has a median survival of 6 months in keeping with the slower renal decline. In the presence of HRS in an organ donor does not preclude transplantation of their kidneys to the patient without a liver disease. Okay. In the liver cirrhosis, there is a vasodilated splanchnic circulation. It is correct due to overproduction of nitric oxide. Regarding terlipressin, why? Terlipressin is a powerful vasopressor V1 receptor agonist which causes systemic vasoconstriction and raises the blood pressure. It is a long-acting and can be given as peripheral boluses. So no requirement of infusion of terlipressin. It is given as bolus. Now, regarding the initial assessment and resuscitation of a patient with an acute upper GI bleed, the following statements apply. Okay, upper GI bleed question, very direct question, simple question I have kept. Platelet transfusion is not routinely indicated for patients who are not actively bleeding and are hemodynamically stable. Platelet transfusion is indicated in the patients who are actively bleeding and have a platelet count of less than 80 into 10 to the power 9. PCC should be given to the patients who are taking warfarin and are actively bleeding. FFP should not be given unless the patient's prothrombin time INR or APTT is greater than 2.5. Recombinant factor 7A should be given early if available. So this question regarding resuscitation, how will you replace the blood and blood products in upper GI bleed? Yeah, anyone wants to answer, they can put their answers in the chat box. Think about it. Very long answers are given. So you should take time to think, but you should get this because these things we do commonly in the ICU. We get such patients commonly in the ICU, upper GI bleed. You should know how to manage that things. Okay, B, C, D, someone has answered. Yes, someone more wants to answer. F, 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 T, F. Then I've got T, F, T, F, F. Okay, okay. Let's see what the correct answer is. So T, F, T, F, F. Only the first and the third statement, A and C, are correct. Rest all are wrong. Why? Let's see. See, concerning the initial assessment and resuscitation of a patient in upper GI bleed, platelets should not be offered to those who are not actively bleeding and are stable. For those who are bleeding, a platelet count of less than 50 into 10 to the power 9 should be used as a threshold for transfusion. Okay. FFP should be given if the INR is greater than 1.5 times the normal. In the question they had written 2.5. Okay. The NICE guidelines reserve recombinant factor 7A for the management of bleeding where all other methods have failed. Okay, so only A and C were correct. Rest all of them were the false statements. So you should read each and every answer. Like I told you previously, this true and false questions are like 5 separate questions. Each option is a separate answer. You have to think and answer it there itself. And most of the marks are cut in this K-type questions only. A-type question, you can get good marks. Next, with regards to the assessment and the management of patients with acute upper GI bleed, which of the following are correct? Okay. A Blackford scoring system should be used in all patients at first assessment. The Rockall scoring system should be used following endoscopy. A proton pump inhibitor should be commenced in all patients at presentation. Terlipressin should be commenced only once the varicose bleed is confirmed. Aspirin should not be recommended once hemostasis is achieved. So which of the following are correct out of this 5? You can answer in the chat box regarding assessment and management of upper GI bleed. Yes. Who all wants to answer, they can put in the chat box. T, T, F, T, T. Okay. Anyone more? Let's see what the correct answer is. So only the first 2 statements A and B are true, and all the 3 less C, D, and E are the wrong answers. Why? Let's see. See, upper GI bleed is divided into two categories, those with suspected or confirmed varicose bleed and those with non-varicose bleedings. The recommended scoring system is the Glasgow-Blackford scoring system. This allocates a range of scores based upon certain physiological and laboratory parameters, including urea, hemoglobin, systolic blood pressure, as well as the presence or absence of cardiac failure, hepatic diseases, melena, syncope. Score of 6 or more strongly predicts the need for intervention. Okay, so Blackford score is used, and if it is more than 6, the patient needs intervention. Regarding endoscopy, it should be performed within 24 hours in all patients and immediately following resuscitation in those who are unstable. Following this, the Rockhall scoring system should be used to predict the risk of mortality. This assigns a score based on a number of parameters, including the age, presence of shock, comorbidities, diagnosis, where there is an evidence of bleeding at endoscopy. The acid suppressant medications such as the proton pump inhibitor should only be commenced after the endoscopy, and once the varicoses are excluded, there is the evidence of recent bleeding. Okay. Terlipressin is a vasopressin analog which acts to reduce the portal blood pressure. It should be commenced in patient with suspected or confirmed varicose bleeding and continued for no more than 5 days or less if hemostasis is achieved. Okay. So upper GI bleed, another important topic in abdomen. Okay. Let's see what is this. Regarding acute liver failure. Okay. Coagulopathy, jaundice, and encephalopathy must be present for diagnosis. It may be misdiagnosed. It may be diagnosed if encephalopathy follows jaundice within 6 months. And the commonest cause worldwide is paracetamol toxicity. Clinical examination commonly reveals the signs of chronic liver diseases. It is often caused by B and the C viruses. Question on liver now, you can answer in the chat box. Very common topic. You must have read it in the MBBS also. And then in critical care, acute liver failure is very, very important topic. We get many patients in UK with this liver failures. So TFFT, TTFFT, yeah. Anybody more wants to attempt? Can write your answers in the chat box. Let's see what the answer is. So only the first two statements are correct, A and B. Rest C, D, and E are false. Why? Let's see. So acute liver failure, the mortality rates exceeds 50% without transplantation. Just 1 minute. ACE, okay. The diagnosis of ALF is based upon the triad of jaundice, loss of synthetic function, that is the coagulopathy, and encephalopathy, in the absence of signs of chronic liver disease. The rate of progression from the onset of jaundice to the development of encephalopathy is used to categorize the liver failures into hyperacute, acute, or subacute. Okay, there are many classifications are given for acute liver failure. When you go into the books, acute, hyperacute, you can see there are different types of classification. You should be thorough with that also. A question can come on that also. Okay. The causes of acute liver failure vary according to geography. In many developed countries, the commonest cause is the paracetamol toxicity, over half of all UK cases, although it is comparatively uncommon in Western nations and very rare in developing world. The commonest cause worldwide is viral hepatitis caused by hepatitis A, B, and E. Okay, so paracetamol is not the commonest cause all over the world. If the world they are asking, the commonest cause is hepatitis. If they are asking specifically about UK, then it's paracetamol. Acute hepatic failure caused by hepatitis C is extremely rare. Other causes are toxins, autoimmune diseases, then primary sclerosing cholangitis, hepatic ischemic pregnancy related, and inherited diseases. Okay. So I think many questions we have covered already. 1 hour is over. I tried to cover as many questions as I could cover and give you tips regarding solving the MCQs. For those who are going for the exam in the next week EDIC 1 exam, I think some tip is that you don't try to read just the explanations. Try to read as many MCQs as possible from the various books. You can find very nice and excellent MCQs on the ESICM site. When you go into the education, there are ACE modules. At the back of each ACE module, there are 50 modules. In each ACE module, you will get some MCQs. These MCQs are given by the EDIC people. So these are very important. Few of them can come directly or related to that. MCQs can come in your exam. I will highly recommend you to read those MCQs. In this 1 hour, I tried to cover most of the topics. It's very difficult to cover each and everything about abdomen in 1 hour. Though respiratory, neurological, and cardiology and infectious are the most of the MCQs come on that. Gastroenterology is also an important topic. I think I will end with this. If any doubts, any questions are there, you can ask. Thank you, everybody.